Welcome to aminacademy.com. In abnormal psychology regarding hypertension, let us do some case studies. A 45-year-old man with 2-month history of progressive headache presented to the emergency department with nausea, vomiting, visual disturbance, and confusion for one day. He denied fear, weakness, numbness, shortness of breath, and flu-like symptoms. He had significant medical history of hypertension and was an beta blocker in the past, but a year ago he stopped taking medications due to an unspecified reasons. The patient denied any history of tobacco, smoking, alcoholism, and recreational drug use. The patient had a significant family history of hypertension in both his father and mother. Physical examination was undertakeable, and at the time of triage, his blood pressure BP was noted was 195 bar 123 mm of Hg, equal to both arms. The patient was promptly started to intravenous laboratory with the goal to reduce BP by 15% to 20% in the first hour. The BP was reckoned after an hour of starting labetalol and was 165 to 100 mm of Hg. MRI of the brain was performed in the emergency department and demonstrated multiple scattered area of increased signal intensity on T2 weighted and fluid attenuated invasion recovery. Images in both the occipital and posterior parietal lobes. There are also similar lesions in both hemispheres of the cerebellum, especially the cerebellar white matter on the left, as well as in the medulla oblongata. The lesions of were not associated with mass effect, and after contrast administration, there was no evidence of abnormal enhancement in the emergency department. His BP decreased to 160 to 95 mmHg, and he was transitioned from drip to oral medications and transferred to the telemetry floor. How would you manage this case? Case review. The patient initially presented with headache, nausea, vomiting, blurred visions, and confusion. The patient's BP was found to be 195 to 123 mm Hg, and MRI of the brain demonstrated scattered lesions with increased intensity in the occipital and posterior parietal lobes, as well as a cerebellum and medulla oblongata. The clinical presentation, elevated BP and brain MRI findings were suggestive of hypertension emergency, more especially hypertensive encephalopathy. Case discussion. Hypertensive emergency refers to the elevation of systolic, that is BP is more than 180 mm of Hg, or diastolic BP is more than 120 mm of Hb, that is associated with end organ damage. However, in some conditions such as pregnancy, more modest BP elevations can constitute an emergency. An equal degree of hypertension but without end organ damage constitutes a hypertensive urgency, the treatment of which requires gradual BP reductions over several hours. Patients with hypertensive emergency require rapid, tightly controlled, reduced in BP that avoid overcorrections. Management typically occurs in an intensive care setting with continuous arterial BP monitoring and continuous infusion of antihypersensitive agents. Now we'll discuss further detail about what is hypertension. The case studies of hypertension is in abnormal psychology highlights the role of psychological factors and emotional regulations, particularly the suppressive and expression of anger in blood pressure regulations. While hypertension itself is not a primary focus in abnormal psychology, studies in psychology can explore cases where psychological distress or behavioral pattern contribute to elevated blood pressure. Resources for such case studies include textbook like Case Studies in Abnormal Psychology. Now we'll discuss psychological factors in hypertension. What are the psychological factors causes hypertension? Anger expression. Research suggests that a collinear relationship between anger and hypertension, where both excessive suppression, inhibition, and overt aggression can increase blood pressure. Assertive and constructive expression of anger may be associated with lower blood pressure. Stress. Stressful life events and chronic stress can contribute to higher blood pressure, making stress management techniques such as mindfulness, cognitive behavioral therapy, CBT, and physical activities important for cardiovascular health. Psychophysiological studies. Abnormal psychology uses physio psychophysiological techniques like a brain imaging, that is MRI, to study the link between brain activity, emotional states, and physiological responses, including those related to hypertension. Some examples from case studies. Suppressed hostility. Early observations noted that patients with hypertension struggled to express anger, suggesting a link between chronic suppressed hostility and high blood pressure. Stress and health behavior. Cases in abnormal psychology textbooks often explores how stress can influence health-related behaviors like smoking or alcohol consumptions, which in turn contribute to cardiovascular risk factors including hypertension. Finding case studies. Academic databases. Search academic databases and journals for articles on psychophysiology, health psychology, and psychological aspects of hypertension. Clinical resources, online platforms such as Sage Edge or other educational resources related to abnormal psychology may provide access to relevant case studies for educators and students. So far, we discussed a little about hypertension, some case studies. We have done. Please subscribe our YouTube channel.